Welcome back to the Derm Club podcast. This is Dr. Hannah Kopelman. Today we have a great show about the latest non-surgical treatments for hair restoration. This is important because hair loss affects both males and females. More than 80% of men and nearly half of women, which is important medically and cosmetically, suffer from hair loss. To help better understand the advancements in medical hair loss treatment, we are traveling all the way to Madrid, Spain, to chat with Dr. Sergio Vano Galvan, a dermatologist, trichologist, and hair surgeon. Dr. Galvan serves as the director of the trichology unit of the Ramón y Cajal University Hospital and the trichology and hair transplant unit of the prestigious Pedro Jaén Group Clinic. I'm gonna have to start over.
Don't worry, Hannah.
Oh God, I think someone doesn't want me to do an interview today.
Don't worry.
We'll start over. Welcome back to the Derm Club podcast. This is Dr. Hannah Kopelman. Today we have a great show about the latest non-surgical treatments for hair restoration. This is important because hair loss affects both males and females. More than 80% of men and nearly half of women suffer from hair loss, which is important medically and cosmetically. To help better understand the advancements in medical hair loss treatment, we are traveling all the way to Madrid, Spain, to chat with Dr. Sergio Vano Galvan, a dermatologist, trichologist, and hair surgeon. Dr. Galvan serves as the director of the trichology unit of the Ramón y Cajal University Hospital and the trichology and hair transplant unit of the prestigious Pedro Jaén Group Clinic in Madrid. He is also a member of the board of European Hair Research Society and the director of the International Master's Degree in Trichology and Hair Transplantation of the University of Alcalá. Dr. Galvan, it's so exciting to have you on the Derm Club podcast to discuss a topic I am very passionate about, hair.
Thank you very much, Hannah. It's a real pleasure for me to be here.
To begin, let's start with a very basic question. What causes hair loss in some people, and why are some people never affected? Like my grandfather, who was 90 years old and he had a full head of hair.
Well, it's important to remember that we have more than 100 different types of alopecia. So we have different causes like hormones, like stress, like autoimmune disorders, or even drugs. So first of all, it's really important to perform a correct diagnosis to every single patient in order to select the proper treatment. And alopecia is a disorder that affects more than 50% of population, so it's really relevant to properly diagnose each type of alopecia.
Is there a good window of time to use certain medications like Propecia for the greatest effect?
Yes, the sooner we use these medical therapies, the more effective they will be. So it's important to do an early diagnosis and start the effective treatment soon, because we are going to even improve, not only to stabilize the patients with alopecia, but also to improve. I receive in my office a lot of patients asking for hair transplantation, and I prefer to start with medical therapies. And the majority of these patients even avoid the hair transplant. They improve with medical treatment enough to obtain a good hair density.
What are the new developments in the treatment of a hair loss disorder called androgenetic alopecia?
Well, androgenetic alopecia is the most frequent cause of alopecia, both in male and female patients. And in the last 5 or 7 years, we have seen a lot of new emerging therapies, especially oral minoxidil, which has been a revolution in the treatment of androgenetic alopecia, but also oral dutasteride, mesotherapy with dutasteride, PRP, platelet-rich plasma, and also other anti-androgenic drugs like oral bicalutamide. So we are using treatments that are really innovative, and 10 years ago, we didn't have these treatments available.
So I know that topical minoxidil is very commonly used in the US. It's also known as Rogaine. But now, there's this oral minoxidil that's coming into play. It's not necessarily FDA approved yet in the US for use for hair loss, but it's used for other treatments to treat other things like blood pressure. So, what is the difference between oral minoxidil and topical minoxidil, and when do you know which one to prescribe?
Well, it's a very interesting question, Hannah. Here in Spain, more than 95% of treatments that we use in androgenetic alopecia are off-label, especially oral dutasteride and oral minoxidil. In my experience, oral minoxidil is more effective than topical minoxidil, but it has a really great advantage compared to topical minoxidil, and it's the good compliance by the patients. It's more comfortable to take a pill than to apply a topical product. So in our view, oral minoxidil can be considered even the treatment of choice with oral anti-androgenic drugs in the management of male androgenetic alopecia. And it's also the treatment of choice in our view in androgenetic alopecia in women. In our experience, it's a really safe therapy. We have recently published in the Journal of the American Academy of Dermatology a multi-center review of more than 1,400 patients treated with oral minoxidil, and the rate of withdrawal of the drug was only 1.7% of the patients. So although we can see some side effects like hypertrichosis, they are easily manageable with dose adjustment, and we are using this treatment not only in androgenetic alopecia but also other types of alopecia with a really, really good result.
So it's interesting because often when people say, "What should I do for my hair loss?" Like friends of mine, and I say, "I would, you have androgenetic alopecia. I think you should start with something called Rogaine or topical minoxidil. You could buy it at the local store." And they're like, "Well, do we have to do this every morning, every night? How long do we have to do it?" It just is a very big commitment, and people don't want to keep up with that commitment. So I can imagine that having an oral pill is just much easier, and people are more willing to adhere to using it for longer.
Yes, absolutely. And I always explain to my patients that the success in a hair disorders treatment is the long run maintenance of the treatments. So with oral minoxidil, we have a really excellent compliance with the patients, and this treatment is easily maintained over time.
When you prescribe oral minoxidil, are you using it as a monotherapy, or are you also prescribing other medications along with it?
Well, it depends whether we are dealing with a male or a female androgenetic alopecia. In male patients, we try to almost always combine an oral anti-androgenic drug, mainly dutasteride, with oral minoxidil and sometimes topical minoxidil. We do combine oral minoxidil and topical minoxidil. On the other hand, in female patients, our treatment of choice is oral minoxidil at a mean dose of 1 milligram daily. And in some cases, we only use this treatment as a monotherapy. But in other female patients, especially those with signs of hyperandrogenism, we also add an oral anti-androgenic drug, spironolactone, bicalutamide, or even finasteride or dutasteride.
So you mentioned oral dutasteride. What is the mechanism of action of that drug?
Well, this drug, this molecule is really interesting. It's a dual 5-alpha reductase inhibitor that inhibits the 2 isoenzymes of this enzyme. So it's more effective with a similar safety profile compared to finasteride. In our view, it's really effective, and it has another additional advantage. It has a longer half-life of 5 weeks compared to 12 hours of finasteride. So it can be used not daily, but every other day, or even twice weekly. Only 2 pills of 0.5 milligram every week. It's a good maintenance therapy that the patients are really tolerating very good. And in some men with androgenetic alopecia, especially those with fear to the sexual adverse effects, I use these low doses of oral dutasteride with a really good result.
What are the concerning side effects for both men and women? I understand for men, you mentioned sexual side effects, but I think with many of these hair loss drugs, treatments, um, that is a concern. Like for finasteride, you're concerned about impotence and sexual dysfunction. So, what other side effects are there?
Actually, in clinical practice, we explain to our patients that the sexual side effects of or dutasteride or finasteride in young people, in healthy young people, are almost similar to placebo. It's really different compared to the treatment of benign prostate hyperplasia, and it's a really safe treatment. The majority of patients developing sexual side effects in our experience are due to the nocebo effect of having heard some horrible things regarding these drugs, but in clinical practice, it's really safe. However, there will be always patients that will prefer not to take oral medications, and in those patients, we can use topical anti-androgens like topical finasteride or even mesotherapy with dutasteride. Regarding female patients, we should remind them that it's really mandatory to avoid pregnancy during the treatment, and after stopping the treatment, also to avoid pregnancy during a period of time that will depend on each specific drug. For finasteride, it's 1 month, but for dutasteride, it's a longer period of time of 6 months.
So, when you have a patient come in and they clearly have androgenetic alopecia, either they're male or female, how do you differentiate whether they should get finasteride, should they get oral minoxidil or topical minoxidil, or should they get dutasteride?
Really good question, Hannah. It would depend on the features of the patient and on the clinical history, on the clinical examination. We will see some features. For example, if the female patient has hypertrichosis or hirsutism, we probably will not use oral minoxidil, or at least we will start with a lower dose. If the patient has signs of hyperandrogenism like acne, seborrhea, we can use an oral anti-androgenic drug that also will improve these signs, like oral spironolactone or oral bicalutamide. And for men, we use more or less a similar strategy in the majority of patients, which is to give them the oral anti-androgenic drug, or if the patient prefer not to take oral medication, we use topical finasteride or mesotherapy with dutasteride, and we try to add topical or oral minoxidil. We try to go from the beginning with the combination of oral anti-androgenic drug with oral minoxidil, because in our experience, and there are some studies regarding this issue, for men with androgenetic alopecia, it's really important to give them any type of anti-androgen. It's the most important treatment because it will stop the progression of the alopecia, while in the patients treated only with minoxidil, in men treated only with minoxidil, some men will worsen over time, and this treatment with oral or topical or injected anti-androgenic drug will be mandatory in the strategy of treatment.
Fascinating. So, have any of the treatments shown to be more effective and than another one? And I understand it really depends on the clinical exam and presentation and the clinical history. And as also, does oral dutasteride help grow eyebrow hair? Because I know that could be a concern of many patients as well.
Yes, well, regarding the first question, I have recently posted on my social network accounts like a ranking of the most effective treatments, both in male androgenetic alopecia and female androgenetic alopecia. In my experience, the most effective treatment in male androgenetic alopecia is oral dutasteride, without doubts. In second place is oral minoxidil, and then we can see improvements, of course, with oral finasteride, with a topical minoxidil, with injections of dutasteride, and at lower level with PRP microneedling or even low-level light therapy. In female patients, in my experience, the most effective treatment in general is oral minoxidil. followed by oral spironolactone or oral bicalutamide. And there are some female patients with signs of hyperandrogenism or any hyperandrogenism syndrome, in which the most effective treatment will be the combination of oral minoxidil plus an oral anti-androgenic drug. Regarding the second question, if dutasterate improves the eyebrow growth, it does not improve because the mechanism of action affects the hair of the scalp, but not the hair of the eyebrows.
Are there any drugs that you can treat patients with who have both hair loss on their scalp and on their eyebrows with a single drug, or does it usually take a polytherapy approach?
Well, in patients with that want to increase their hair density in the eyebrows, oral minoxidil is a really effective treatment. It has been recently published the improvement, for example, in the eyebrows in patients with frontal fibrosing alopecia treated with oral minoxidil. And we can also use topical minoxidil combined with a topical prostaglandin like latanoprost. It's a compound that we usually prescribe in our patients. Topical minoxidil 5% plus topical latanoprost 0.005%. It can improve the hair density in the eyebrows. And for eyelashes, which is another interesting question, we only use topical prostaglandins like topical latanoprost. But we try to avoid, we avoid topical minoxidil because it can produce an irritative process in the eye.
So you mentioned oral bicalutamide. Can you please explain to us what is the mechanism of action? You also mentioned that it helps to treat seborrhea. And why is that? I have never heard in the past of other hair treatments being able to simultaneously treat seborrhea.
Well, the history of oral bicalutamide is really interesting. It's an analog of flutamide, which was an anti-androgenic drug that we used to prescribe in the past, but it produced hepatotoxicity, a liver disease. So we stopped to use flutamide, and we started to see the clinical trials of the urologists treating metastatic prostate cancer. And we observed that they used a second-generation anti-androgenic drug called bicalutamide. And this treatment was really safe. The safety profile was excellent. The urologists are using this drug for more than 10 years. And we started using it in androgenetic alopecia in women with really good results. The safety profile is really good, and the mechanism of action is very similar to oral spironolactone. It's an androgen receptor blocker, so it not only improves hair density, but also improves seborrhea and other signs of hyperandrogenism like hirsutism or acne. It's a really interesting treatment that we are using more and more in the last years.
Is that when you say hirsutism and acne and hair loss, it kind of starts to sound like someone who has polycystic ovarian syndrome. Would this be an appropriate drug to give a patient with PCOS? And would you combine the therapy with spironolactone as well?
Well, it's important to remember that it's an off-label use. So the patients will see horrible things in the prospect of the drug, but we have to explain them that the mechanism of action is really interesting for this profile of patients because it will improve the signs of hyperandrogenism. And in these patients, we start the treatment with oral minoxidil combined with oral bicalutamide or oral spironolactone. In some patients, we are combining both drugs, but in my view, I think that some patients will benefit from taking only one type of the drug. If they are not improving enough, this treatment should be switched to the other drug. But I think that the combination does not produce any benefit for the patient.
Before we move on, I wanted to ask you, do you use topical minoxidil at all anymore, or are you immediately prescribing oral minoxidil?
Well, really interesting question. Of course that we are still using topical minoxidil. Topical minoxidil is really useful, but it's not the same to prescribe topical minoxidil twice daily, then say to the patient that please use topical minoxidil 3 or 4 nights a week. They can use topical minoxidil combined to oral minoxidil, but as an additional therapy. The mainstay of treatment will be oral anti-androgenic drug and oral minoxidil. And in some patients, for example, if they want to improve more the frontal area, we prescribe topical minoxidil some nights a week. And this is a very comfortable treatment. The patients don't feel that they depend completely on topical minoxidil, and they have a really better compliance in the long term.
Okay. And many people always ask me, do I have to use it for the rest of my life? And I heard that if I stop using it, my hair will fall out. Is this true?
Well, yes, this is one of our biggest deal with the patients. Well, I usually say nobody knows what will happen in 30 years. So this is a treatment that it's more effective nowadays. It's not curative, so it should be used in a continuous way, but probably in the near future, we will have new emerging therapies that will be more comfortable to use. And I really encourage the patients to maintain the treatment. I tell them that these new therapies didn't exist 10 years ago. So probably in 10 years, we will have newest therapies that will be more effective and more comfortable than the current ones.
Okay. Is the reason for the potential shedding of hair because you are in the growth phase, and then once you stop it, you go into the resting phase of hair loss?
Yes, with oral minoxidil, we see also this shedding effect. We tell to the patients that they should not worry about it, but it's a phase that they should pass to feel the improvement. It's like after a hair transplantation, the patients worsen in the first months, and then they will improve. So we tell them, and it's not a problem in our daily practice.
I want to move on to some other topic called using botulinum toxin for hair loss. There are some clinical trials that are going on using Botox. And can you share with us a little bit more about this?
Yes, it has been one of the newest therapies recently described for androgenetic alopecia. I don't have personal experience yet, but I'm looking forward to trying it in some patients. The rationale for this treatment is that when injecting botulinum toxin in the scalp, we relax the muscles of the scalp and we increase the blood supply to the hair follicles, increasing the wash-up of DHT and other mechanisms with TGF-beta. So it can improve androgenetic alopecia. And there are some trials that have demonstrated that it can improve in monotherapy the hair density, both in men and female patients with androgenetic alopecia. However, the big problem in my view is the cost of the product. So if I don't see a great improvement in the hair density of the patient, this treatment is not going to be probably worth it for the patients because it's going to be a very expensive treatment. But on the other hand, it can be an additional treatment in our armamentarium that it's a non-hormonal treatment. So it can be interesting for very selected patients with androgenetic alopecia.
Let's talk about, we spent some time now speaking about androgenetic alopecia. I want to switch gears and talk about another type of hair loss called frontal fibrosing alopecia, also known as FFA. So FFA is on the rise. If you look it up, people are talking about it and saying they're seeing a lot more of it in clinical practice. What do you hypothesize as the risk factors that are leading to an increase in the disease?
Well, frontal fibrosing alopecia is nowadays the most frequent type of cicatricial alopecia. It's like an epidemic. It's a fascinating disease because we don't know the cause yet, but we know that there's probably a genetic susceptibility. There's an autoimmune and a hormonal mechanism because it mainly affects postmenopausal women, and some hormonal treatments can trigger the disease. But in our view, there's probably an environmental factor that it's playing a role in the pathogenesis of this disease. There are some research regarding or associating some products like sunscreens or moisturizers with this disease there's no a solid evidence to avoid the use of these products. But in my view, I really believe that there's an environmental factor that it's justifying this rise in the incidence of this disease.
What are the therapy options that are out there for FFA?
Well, in first place, we should explain to our patients that this is a cicatricial alopecia. So the objective is to stabilize, but it's very difficult to improve the hair density in our patients. I tell to my patients that the objective will be that in 5 years, the recession of the frontal hairline is the same that today. This is a success because this expectation of result is very important to manage them with our patients. The most effective treatments from a scientific point of view are oral anti-androgenic drugs, especially oral dutasteride, and oral anti-inflammatory drugs, like, for example, oral anti-malarial drugs and steroids, mainly intralesional or used as topical anti-inflammatory treatments. The strategy of the treatment in this cicatricial alopecia is usually to combine oral dutasteride with some anti-inflammatory drugs. Depending on the signs of inflammation on trichoscopy, we decide to give to the patient an oral anti-inflammatory drug, topical anti-inflammatory drugs, or even intralesional anti-inflammatory drugs. And one of the questions that is most frequently asked to us in the consultation is if a hair transplantation can be an effective measure or treatment for patients with frontal fibrosing alopecia. And of course, it can be performed in some selected patients, but the result will be not as good as in androgenetic alopecia, and the survival of the grafts will decrease over time. If the patient accepts this limitation, it can be an interesting treatment to increase the hair density, but with a transient result.
And that the reason for that is the hair follicle has scarring.
Yes, I think that the patients with frontal fibrosing alopecia has a special condition that produce fibrosis around their hair follicles and this inflammatory process that also affect to the transplanted hairs.
So it sounds like the initial goal when treating FFA is to first stop the inflammation so that you can stop that recession of the hairline. Once you've kind of decreased the inflammation, do you tell patients they have to stay on a maintenance therapy for long term? What is the usual guidelines for that?
Yes, this is a real interesting question, Hannah, that probably nobody knows yet. I think that in FFA, the treatment probably should not be maintained in the long term, but we should maintain the treatment for a few years. Once we check that the patient has achieved the stabilization in the frontal hairline and in the temporal hairline, we usually try to taper down to decrease the dose and to maintain another year. And if the patient is stabilized after 2 or 3 years, we try to stop the treatment. In our personal experience, we have had some patients that have maintained perfectly without treatment after this withdrawal of the drug. And we have had other patients that, on the other hand, they have need to restart the treatment because we observe a reactivation of the disease and the progression of the frontal hairline. So I think that it will depend on each single patient, depending on these factors like inflammation, the pattern of the frontal fibrosing alopecia, like pattern 2, this pattern diffuse, that we can see a lot of lonely hairs, in my experience, has bad prognosis. So in these patients, probably we should maintain the treatments for more years compared to the patients with other patterns.
So, there's a lot of talk about JAK inhibitors. I'm sure you are aware. And it started as using JAK inhibitors for alopecia areata, and now they're talking about using it for other things like frontal fibrosing alopecia. What is your opinion on the use of JAK inhibitors?
Well, I think that JAK inhibitors are one of the biggest revolutions in the field of hair disorders. I think they are really useful for alopecia areata, and they are going to change the way that we manage these patients with this disease, with alopecia areata, in the next 5 years. In Europe, we are not using JAK inhibitors like in the US because we have some limitations. It's off-label treatments, very expensive, but I'm sure that once they obtain the approval for alopecia areata, we will use in a lot of patients, and a lot of patients will benefit from this treatment. Besides alopecia areata, it makes a lot of sense to use JAK inhibitors in some autoimmune alopecias like frontal fibrosing alopecia or even lichen planopilaris. There's not a huge evidence yet regarding the use of JAK inhibitors in those alopecias, but I think that in the next years we will see some clinical trials evaluating the effectiveness of this family of drugs in these alopecias, and I'm sure that it will be really effective.
I'm hopeful for them too. There's a lot of research going on with them, so I'm sure we'll see a lot of data come out in the next couple months or in the next few years. What is your opinion on low-level light therapy? There's a lot of mixed opinions here. Some people say it doesn't work. Some people still suggest it to their patients. What is your opinion?
My personal opinion regarding low-level light therapy is that it's a scientifically demonstrated effective therapy, but the level or the degree of effectiveness is low yet. I think that the best parameters of this treatment needs to be determined yet, and this is, I think, we are in the at the beginning of the research of this treatment for androgenetic alopecia. We have a lot of clinical trials demonstrating the effectiveness of this therapy in men and female patients with androgenetic alopecia. In my personal experience, it's not as effective as shown in the clinical trials, but I do believe that it's an effective treatment, but with a low level of effectiveness yet.
Okay. Now there's another treatment out there called PRP. Can you share with us how it works, and does it work better in females than males? I've read, many reports that say females seem to have some better results and it shows to be more effective. And why is that?
Yes, I agree. Platelet-rich plasma is an innovative treatment that consists of getting the blood of the patient, isolating after centrifugation the platelets that are the cells that release the growth factors. And the growth factors are the really mainstay of this treatment because they produce an activation of the Wnt pathway, and they produce that the hair can increase its diameter. In my personal experience, it's an effective treatment, but as I said before, with low-level light therapy, I have seen a degree of effectiveness that it's lower compared to the clinical trials or even the results of other doctors. I think it's effective, but it doesn't work in all patients. So before telling to our patients that it's a really effective treatment, we should try, for example, 2 sessions in a single patient to see the level of effectiveness, the degree of effectiveness. I agree that it's more effective in female patients compared to male patients. And I agree that it's a really interesting treatment for some patients with a specific profile. For example, for female patients that are looking for pregnancy, we cannot use other anti-androgenic drugs. We can use topical minoxidil, but we can use this treatment of platelet-rich plasma. So I do use PRP in the management of especially female androgenetic alopecia, but it will not be my first or my second choice.
Are there certain hair loss disorders that you find that PRP is more effective for?
I have tried PRP before and after hair transplantation, and I have not seen a special benefit for patients after this procedure or even before this procedure. On the other hand, I want to share with you that for cicatricial alopecia, it has been a great surprise that PRP has worked really good in my experience for decreasing the inflammation. So for this indication, we are using more and more PRP combined with intralesional injections of triamcinolone, and we are seeing really good results in terms of decreasing inflammation and even a slight regrowth of the still non-damaged hair follicles in some patients with lichen planopilaris.
That's very exciting. You mentioned hair transplants. What is the role of a hair transplant in the treatment of female or male androgenetic alopecia?
Yes, hair transplant is an additional treatment that should always be accompanied by a medical therapy, because I explained to our patients that hair transplant is not curative. So if we perform a hair transplant and we don't give medical therapy to a specific patient, the alopecia of the patient will worsen over time. So we should start with a medical treatment. As dermatologists, we know a lot about medical therapies of alopecia, and in some patients, we will add the hair transplantation. But the hair transplantation is not a substitute of medical therapy.
Before we wrap up, I want to talk about a little bit about folliculitis decalvans. Can you share with the audience what is folliculitis decalvans? Not everybody knows, and what are the new treatment options out there for it?
Yes, folliculitis decalvans is the third most frequent type of cicatricial alopecia. It mainly affects young men, and it produces cicatricial patches of the scalp, mainly on the crown, with pustules that produce itching and trichodynia, pain, even bleeding of the scalp. The pathogenesis is not well known. It seems that an abnormality in the microbiome of the scalp of the patient is playing a role. But what is true is that we don't have a curative treatment, and it produces not only an aesthetic problem, but also a symptomatic problem, because it produces pain and even itching on the scalp. The most frequent therapies are intralesional corticosteroids like triamcinolone, and oral anti-inflammatory drugs like doxycycline, some oral antibiotics, oral steroids, and of course other treatments like newest treatments like photodynamic therapy, or even we can, in some selected patients after the stabilization of the disease, perform a hair transplantation to try to increase the hair density in the cicatricial area. But as I told before, in frontal fibrosing alopecia, the main limitation of hair transplant in this disease is that the survival of the grafts worsen over time, and that the result is usually not permanent but transient.
Well, there's so many exciting things going on in this specialty. Where do you see the future of hair loss medical treatment options?
Well, probably the future is regenerative medicine, the stem cell therapies that, in my view, they are not working nowadays, but they are under research, and probably in the next 10 years, perhaps in the next 7-8 years, we will see new results, and we can offer this new option for our patient to recover the hair that they have lost in some area of the scalp. I think that they will definitely be a mainstay of the treatment in the near future, or in 10 years at most. And on the other hand, in other alopecias, I think that alopecia areata will really be changed by the use of JAK inhibitors and other biological drugs. And in the field of hair transplant, probably the new robotic devices will change the way that we understand hair transplantation nowadays.
Thank you so much, Dr. Galvan, for allowing us to better understand the advancements in medical hair loss treatments, and we look forward to speaking again with you in the future. Thank you for
Thank you,
joining me
Hannah.
today.
Thank you very much, Hannah.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.